All right, everybody. People are coming in, getting their food. Welcome. I'm going to get us started because I don't want to miss a minute of what you're about to hear. I'm Jürgen Onosser. I chair the psychiatry department here at UW. And it's just a tremendous pleasure for me to introduce today's grand round speaker, Dr. Myrna Weissman. Myrna is a professor of epidemiology in psychiatry at Columbia University. She really doesn't need much of an introduction. The fact that some of our very best and brightest rock star alumni are here. When they learned about Myrna being here, it tells pretty much everything. Myrna was rated recently as one in the top 10 epidemiologists in the United States to have a major impact on public policy and public health. I'm one of those psychiatrists who trained in epidemiology, so Myrna was really an inspiration for people like me in my generation doing this kind of work, really helping us understand from more of a public health perspective the epidemiology of mental illness. Those of us who are clinicians, we tend to think about the numerator. The numerator is the person who sits in front of you in your waiting room. Learn how to do really great work, and people like Myrna say there's a denominator. There's a lot of people who have this problem, and you might not be seeing all of them, and how do we better really understand both of those? And I think if you both understand the numerator and the denominator, then we can do some really, really fabulous work. So that's why I'm super excited to have an epidemiologist here. All right, say a couple more things. Myrna is tremendously productive. She has over 600 publications, 11 books. She's really, I think, done two major lines of work. One of them is the work she'll talk about today, which is multi-generational studies of what happens when somebody is living with depression, what happens in future generations. And I'll get back to that in just a little bit. And the other work is developing interpersonal psychotherapy, interpersonal therapy, which is, in my mind, one of the most portable, robust, usable psychosocial interventions that I've ever met. I'm a huge fan. I think that Myrna has spent a good portion of her career really developing that notion and is now working with the World Health Organization, she told me yesterday, to adapt that work to see how that would work for people who live in Muslim countries. And that's another thing I could say about you, which is you're not afraid of anything. You'll go out there and say, this looks like an interesting challenge, why not try it? And that's wonderful. Why is Myrna here? Why did I invite her to give us a grand round? Besides all of the things I already said, I'm going to share just a little bit of a story. So about 30 years ago, very early on in my career, I spent time at the World Health Organization in Geneva. And at the time, people weren't paying a lot of attention to mental health. And I had an opportunity to talk with the person who was the Director General of the World Health Organization. That was very early in my career. I made a very passionate plea about the fact that someday we'll cure all these infectious diseases and then we'll have to worry about people's mental health. And the woman said, well, she said, you know, there's never going to be any money for that, but if I only had $1 to spend on mental health, what would I do with it? And I said, you would use it to treat a pregnant woman who's depressed. And she said, well, why would that be? I said, because that woman is got a baby who's going to live in an environment where there is very high cortisol levels, where there's a lot of things that are going to affect this child's brain, and that child is born with a different brain, and now you have a child who is a very fussy baby with a mother who is really struggling because she's anxious and depressed. And that's a bad combination, and there isn't going to be good attachment that needs to happen early on. And a couple of years down the road, you'll have an adolescent who is struggling with depression and anxiety, and maybe a mother at an age that's way too young. And the woman said, okay, I sort of get that, but do you have any data for that? I said, no, that's just really based on my clinical intuition, and it's pretty much true, and it still is true. I still believe this story. And Myrna is the person who has all the data behind that story. And as we in our department, one of the areas that I really want to help develop, and several of you are here for this reason, is good work in maternal and child mental health and that diet, and what do we do to really work and help on that diet. And this is why I'm really delighted to have Myrna here. I'm sorry I went on so long with that story, but I'm very happy to have you here, and thank you.
Well, 30 years ago, as a mother of 4 children under the age of 6, I had the same idea, and I was starting my career, and I decided to try to investigate it, and I have found, and I'll show you those slides, what you know as common sense. But now we have some figures and hope that that will have an impact on the future. So I'm glad that you invited an epidemiologist. This is what I'm going to talk about. And I'm going to try to talk fast, and I may end before I end because I want to have a chance to talk to this group. I'm going to talk about the depressed mothers and their offspring, our 3-generation study. I'm going to talk about the work we did trying to break the cycle of depression. I'm going to talk about my concern about perinatal depression and what to do about it, and the recent U.S. Preventive Task Force for Depression. And then I'm going to end with the paradox. Just to remind you, for those who weren't there, in the 1970s, the conventional wisdom held that depression was a disorder primarily of middle-aged and menopausal women and didn't occur in children because of their ego development not being fully available. And in fact, an NIMH conference was held, and it was reported in the Psychological Bulletin in 1978. I wasn't there, but I certainly took out the quote, that the notion of a syndrome of childhood depression rests largely on surmise. So it was against that background that I started my study. First of all, there was the epidemiologic data, which was coming out in the 1980s, and these are the age-specific rates of depression in the United States, the ECA, and it showed that most depressions, in fact, began before the age of 20. This is the first onsets of depression. So there was childhood depression, not high rates, but it was there. So the notion that it was just conjecture was probably not true. Based on that, and this was the first study I did, I started this study of families at high and low risk for depression. High risk was defined as having a proband with definite major depression being treated in a psychopharm clinic. And low risk came from the ECA, the epidemiologic study that brought us this. And they were people living in the same community who did not have depression and who we interviewed about 5 or 6 times and were sure that they didn't have depression. The design was simple. We were going to study all of their offspring. And we did the same thing in the low risk study all of the offspring. Interviewers were always blind as to whether the offspring came from a depressed or a non-depressed family. And all of the data were reviewed by psychiatrists or psychologists to do a best estimate diagnosis, again, always blind. Now time goes on, and our offspring married. And we then began to have more offspring. And that became the 3rd generation. And the study has gone on for 30 years. We're actually doing our 7th wave right now. And in fact, we have about 40 4th generations. So 30 years later, we're in the midst of the 7th wave. And 6 waves later, this is what we found. First of all, there was no difference in demographic and other characteristics between the offspring of the high and the low risk group. About 60% were females. Their age at first interview was about 19. At the age of the last interview was about 47. The number of years between interviews was about 28 years. That's why we call it the 30-year follow-up. And they were interviewed on the average of 5 times. And we also got them in between at the 3rd and 4th interview, so that there wasn't a differential information effect that could affect the findings. And this is what we found. I'm sorry, this slide should be made better, but I didn't have time, but this is the major finding, that there is over a 3-fold increased risk of major depression in the offspring of depressed parents as compared to the offspring of the low risk. And there's a bit more phobia, a little bit more drug dependence, a little bit more of every disorder, but it's very highly specific. It isn't just that they're sick, but that they have depression. And these are just show you some graphs that, again, we showed that the age-specific rates are mostly, they're actually about the same in the high and low risk group, the offspring, but that the high risk group just has a lot more. And that there is prepubertal onset depression. And in fact, you don't see that in the low risk, but you do see it in the high risk group. So the 1970 quote from NIMH that we're not sure about it, it's a surmise, I think we can discount that childhood depression and certainly adolescent depression occurs. And in fact, the peak onset is somewhere around age 15. And it's interesting here, there's a little peak in the perimenopausal period for the low-risk group. But it isn't that a lot of onsets occur later in the low-risk group. And we show the female, the sex difference remains in both groups, with women having higher rates than men. The lowest risk is in the males in the low-risk group. We show that anxiety disorder is, we've shown this in other slides and other analysis, that usually the depression is, the sequence is that you have an anxiety disorder prepube and the depression comes later in adolescence, and you see the high rates of anxiety disorder even in the low-risk group. And that's mostly phobias. Panic disorder occurs later in the 20s. And this is about the third generation, that the third generation, that's the grandchildren, who have a grandparent with depression and a parent with depression, have very high rates of depression, and is quite specific to depression. And the average age of the third generation is about 18. So they have a long way to go to do something about these rates. Now, this was the most shocking finding, mortality. Now, this was updated in August 8th, 2016. In the last few weeks, we have found 2 more suicides, and we wanted to check it out to make sure. But overall, the mortality rate is higher in the high risk than the low risk. But the mortality from natural causes doesn't vary. But the mortality from unnatural causes, and this is now up to about almost 5%, is quite extraordinary. And unnatural causes are suicides and some where there's drug overdoses, but we can't be sure it was intentional or not intentional. And there was one accident that we thought was drug-induced, but we're not sure, but we call it an unnatural death. And you can see here that the mean age of death is much younger in the high-risk group. And once we put in those 2 other suicides, those were real suicides, not just overdoses that we're not sure of, the rates, the mean age of death is going to go down. An alarming thing is that when we've looked at the third generation, we see increased rates of suicidal ideation and suicide attempts in the high-risk group. They're only about 18. Just to summarize, the offspring are now 48. They have more depression. It's usually in adolescence. It nearly all occurs before age 40. Those of you who are studying geriatric depression, if you do a good interview history, you'll find that most of the time it's occurred much younger. In fact, depression which first occurs at age 50 or 60 is probably a different disorder. I didn't show you all of the findings, but the offspring have more recurrences, more impairment, more divorce. They seek more treatment, and of course the mortality. And then this just summarizes about the grandchildren. So if one is doing an interview for preventive intervention, I think it's good to get a psychiatric history beyond 1 generation, because it's that group that has the 2 previous generations affected that are the highest risk. So somewhere about 8 years ago, 10 years ago, we said, well, what are we going to do about all this? Shouldn't we be offering some help or trying to figure out how to help? We were doing genetic studies, and we argued that it's a complex genetic disorder, But onset and recurrence is precipitated by stressful events in vulnerable people. There are some patients where the cat dies and the person goes into a serious depression, and there are other patients, people you well know, who have terrible things happen. They don't get depressed. They're highly resilient. Now, a depressed parent obviously is a very stressful event in a vulnerable child, as your chairman talked about. And we wondered whether children benefit from a remission in their parents' depression. In other words, in epidemiology lingo, is it a modifiable risk factor? Well, you can't change the parent, but you can change their symptoms. So we started a study. We found out about the STAR-D study. It actually happened one day when we were caught in an airport in Maui from the ACNP, and saw Maurizio Fava, and we started talking, and he told me about STAR-D, which had just started. I didn't know about it. And I said, perfect study, could we study the children? So we quickly wrote a grant, and their study had already started, but they have thousands of people, so we didn't need thousands to do our study. And we got the grant, and our purpose was their purpose was to understand what to do if the first treatment doesn't work, but our purpose was to find out what happens to the children if the treatment doesn't work, and we didn't care what treatment it was. The goal was remission. So this was the study, and we were going to follow the children for about a year after the mothers remitted. We did mothers because there were fewer fathers, and we wouldn't have had a large enough sample. It's also harder to get fathers. And our idea was to study the impact of improvement in mother's depression on the child's diagnosis. And it was a really good design, because those sites, the 14 sites, they were treating the mothers or the fathers, and we had nothing to do with the treatment. We didn't know anything about the treatment. We just said, we trained people to go and assess the children. And that was the study. The mothers treated for depression, mother's outcome. We chose 7 sites that had the most people in childbearing years. For example, Michigan was a very bad site because they had a lot of college students, so they didn't have children. So that was our major reason for choosing the 7 sites. And remember, their study had already started, so we had to move very quickly. So we studied their children, we followed them over time, and we looked at the child's outcome. I won't go through all of it, but this is how it started. If the mothers remitted, this was the score at baseline and 3 months later, and this is the percent of children with a diagnosis. And all of this has been published, but this is just to illustrate the findings. And if the mother didn't remit, the children didn't get better. In fact, they got a little bit worse, but not significantly so. And this is to summarize the finding. There was a decrease in the children's symptoms over the course of the year. It was significantly associated with the mother's remission. And the children of mothers who remitted had a greater reduction in their own symptoms. And it was better if the mothers remitted in the first 3 or 6 months than if they remitted later, because the children remained symptomatic. And also less children remitted if the mother went on for another over 6 months with a depression. Well, this paper was published in JAMA, and we were very proud of it, but of course it got criticism, which it should have. The studies were observational. Without random assignment of treatment, we can't assume that the child's improvement is related to the mother's treatment. It could have been she won the lottery. And in fact, the first clinical trial to test this hypothesis using randomized design was done using IPT at Pittsburgh. I think Nancy was involved in that, and she's shaking her head. I was sure she was. And that was the first one done. And they showed that if the mother was randomly assigned to IPT versus, I believe, treatment as usual, and she remitted, that the kids did better. Holly Schwartz was the principal investigator, and Nancy was one of the investigators. So we set out to do a random assignment. We thought this was a very important area, and we wanted to make sure that we weren't forgotten, or the data weren't forgotten, because it's only observational. So we found a treatment study that was being done by John Stewart, and that was citalopram, bupropion, or the combination. And they were convinced that the combination was going to be better than either treatment alone. And we then were convinced that the children will be better on symptoms and functioning on the more effective treatments. And they had 12 weeks of treatment. And again, we had the treatment teams different than the people who were assessing the children. And the children were on the average about 12. Much to everybody's surprise, there was no difference in the mother's response to any of the 3 treatments. So for the hypothesis of the major adult team, it was sort of a bust. There was no difference. The hypothesis was not supported. So that was a disappointment for us. But our hypothesis was supported in a different way. If the mother received citalopram, the kids got better. This is children's depression symptoms over 12 weeks. And there was no difference if the mothers received the other treatments. And we started to look at other variables, and I'll just present one that was very interesting. The mother said she was better able to talk and listen to her child over 12 weeks if she received citalopram. Remember, these are different teams assessing the parents, assessing the mother, and assessing the child. And the slide I didn't bring is the child on the PBI said, "My mother is more loving and caring," if the mother was on citalopram. So there was some conversion of independent assessments. Now, we looked at other things. We didn't find any difference between treatments in the timing or the rates of remissions. The treatments were well tolerated. The response rate, remission rates were very high. There were no differences in side effects. There was no difference in the amount of treatment that the children were receiving. In other words, it wasn't that the mothers on citalopram were taking their children to a pediatrician for treatment of their symptoms. And we don't exactly know why this is, except some analysis, a secondary analysis. We think that that bupropion may look the same on the Hamilton rating scale, but it produces more irritability. And that there was some findings on something called affective negativity. But I think for our purposes, we showed that the mother gets better, the kids get better. Well, let me just go to the part that is new and I'm very interested in. And this is, of course, the summary that you help the mother, you help the child. So you should treat depressed mothers early and rigorously to remission. And what do you do with perinatal depression? What's the evidence? Well, the U.S. Preventive Task Force published in JAMA in January 4 or 5 articles that got a lot of attention. And they concluded that all adults older than 18 should be routinely screened for depression, especially in the pregnancy and postpartum period. They said screening measures are accurate, that if you screen, you can reduce the rate of depression regardless of the treatment. And they said that remission with CBT increases remission rate from 6.2% to 34%. And that second-generation drugs used during pregnancy are associated with small increases in the risk of potential serious harm, but they didn't go into that very much. Well, independently, we had a Conti Center grant to study the effects of serotonin, SSRIs, on exposure to the fetus during pregnancy. This is work that was done by Jay Gingrich and Marcus Arnage and published in Science, I think very solid work. And they showed, and this is their work, that exposure to the SSRIs during sensitive developmental periods in rodents produced long-lasting effects on behavior, neural circuitry, morphology, and physiology. That the developmental period during which rodents are sensitive to the effects overlaps extensively with human brain development during the fetal period. And because the serotonin system is highly conserved across phylogeny, we suspected, and that was Jay's terms, that similar effects might be seen in humans as SSRIs pass readily through the placenta and enter the fetal circulation. So this was the basis of the Conti Center, and there were a number of studies that were done on rodents, and we were invited as epidemiologists to see if we could find data to test this out in humans. Well, first we found, that everyone knows that SSRIs are prescribed increasingly to pregnant women since their introduction 30 years ago. There's a lot of data on that. In fact, it was in the US Preventive Task Force report. But no studies had undertaken that follow-up of children beyond 6 years of age for depressive disorders, which actually emerge usually after the onset of puberty. And research on the association between SSRI exposure and other neurodevelopment disorders, including autism and attention deficit, has shown some inconsistent results. So we looked for ways of trying to test this out. Now, obviously, you couldn't take a pregnant woman and randomly assign them to SSRI or not SSRI and follow the kids until they were about age 14, which is when you began to see the marked effects in the rodents. So we had to look for other ways, and we did. We found a birth cohort study in Finland and had large samples, and we defined 4 groups. We did a lot of other groups too, but this was the highlight. One group had SSRI and psychiatric disorders. Another had psychiatric, these were depression. Another had discontinued SSRIs at the start of pregnancy, and that was to try to control for severity. And the other group had neither. And you can see these are huge samples. And we looked at the outcome in offspring from birth to 14 years for depression, anxiety, autism, and ADHD. The registry only went up to age 14. Now it's about up to age 19, and we're trying to get funding to redo this. And this is what we found. This is the cumulative incidence of offspring depression by pregnant mother status. And this is the incidence. And this is the age of the child. And this is the effects of SSRI and depression in the mother. You can see that it's over 8%, and that there was very little difference here between the ones who discontinued the SSRIs, who had depression, or who had neither. Remember, age 14 is when the biggest age of risk is starting to occur. These were not popular findings. Okay. This is another way of looking at it. The offspring exposed perinatally to SSRI versus exposed to mother's psychiatric disorder, but no meds. Because we know that depression in a mother, a pregnant woman, has some strong effects on the fetus, and we can't ignore that. So we're looking at what is beyond that. And here you can see for depression, it was highly significant. For anxiety, it wasn't significant, but it was getting a little bit over the bar. But we did not find that for autism or for ADHD. So it wasn't just a general sick effect. And this was the Wall Street Journal. This is a very unpopular finding because treating depressed pregnant women is a real challenge. Now, the WHO says you should use psychotherapy. That is not the practice here because psychotherapy is not usually available. That's one of the paradoxes. And the US Preventive Task Force wasn't even that strong about psychotherapy. they found only 10 psychotherapy studies, and almost all of them were CBT, which is a very good therapy. So we said, we can't believe that, because we knew that people like Nancy Grody were doing treatment studies of IPT. We didn't know about all the other psychotherapies, but we knew there were more. So we set out, we worked with Pim Cooper, who's an expert in doing meta-analysis, and he found 32 studies. And these are the studies. As you can see, Nancy has one of them. Meg Spinelli was in our group. She's at Columbia. Here's Holly Schwartz. So none of these studies were in that report. We just don't understand that. The important thing is not, these are all IPT studies. No, the important thing is not that one treatment is better than the other, but there are psychotherapies that work and that have been tested with controlled clinical trials. And the report underestimated the availability of psychotherapy for depressed pregnant women, and also its efficacy. So I asked Pim if he would just do one of his meta-analysis, and what he did, he found 19 studies of CBT. It was actually 42, 8 for IPT, 7 for supportive, and 8 for other. Yes, this slide had all the studies. It didn't just have IPT. And here he found some evidence for effectiveness. And of course, I know IPT better than the other therapies, so I just wanted to, in the way of advertising, show this is a meta-analysis that was done for over 90 clinical trials of IPT for all different disorders, and that was published this year in the American Journal. The dilemma is that in the United States, psychotherapy is declining. I didn't bring my declining slides. They come from the work of Mark Olson, his office is next door to mine, and he's a leading person in and looking at statistics for the utilization of healthcare, and including medication and psychotherapy. And he has shown that psychotherapy over the last decade, and he has a new paper that just came out, psychotherapy use is declining in the number of people that are receiving it, the amount of time they receive it, and the overall expenditures. And the other slide I didn't bring, but there are data on it, that show that training in evidence-based psychotherapy in psychiatry, psychology, and social work is minimal. Now, we did a survey, and it's out of date now, but I don't think things have changed very much, in which we took every single training program in psychiatry, psychology, and social work, and we did a random sample, and we got 70% of the training directors to respond to the survey. So we went to the person who's in charge, and we found that the rate of providing a didactic and some supervision in any evidence-based psychotherapy was something like less than 6 or 7% of the schools. I think social work was the worst. Psychology was next to the worst. Psychiatry was the best, but really very low. And the reason for that is that accreditation requires now that you have some training in CBT. Now, our figures come from 2006, so it doesn't quite reflect the CBT psychiatric residency training. Now, this is in contrast to what's happening in the WHO, and that's since your chairman was there. And maybe has had a big impact on something that's happened there. Psychotherapy is increasing. The MH-GAP, which is the Mental Health Gap Program of WHO, is launching IPT and CBT. In April, they had a meeting with the World Bank that was held in Washington. That was the first time anything had ever happened like that. The reason that happened is because the head of the World Bank is now somebody who is a public health physician. Dr. Kim. He was at Harvard School of Public Health, and he was at Dartmouth. But usually the World Bank has been headed by somebody in business or banking. And this is the first time public health has had some big say. And their message is no health without mental health. And they had this alliance, which has given a great deal of support for Saxena, who's head of the program at the WHO, to push for MHGAP. And that is to develop procedures and tools so that developing countries, or they call them now resource poor countries, and even middle income countries will have these resources. So the WHO is sponsoring the development of IPT manual for primary care in Muslim countries. That's the one that Lena Verdelli and I are working on. And we're about 3/4 done, and it's been quite an interesting experience because when they send us case material, we find it is not very difficult to put an evidence-based psychotherapy into some of the problems that we see. I'm sure that that would be true for CBT. In fact, CBT already has some manuals, so that does work. Lena is developing a manual for refugees who are entering Lebanon. This is Syrian refugees. And she and Kathy Clockerty are providing IPT training in Haiti and Jordan, and Paula Ravitz is doing it in Ethiopia. And I think got $1 million grant from Grand Challenges in Canada to supplement that work. So let me just sort of summarize what I've been saying. The offspring of depressed parents are high risk for long-term recurrent depression. There is every good reason to do a family history when you assess a child, because that might be a clue to who should get more rigorous treatment. You see the risk across several generations, and the risk is for depression. It isn't for schizophrenia. And we didn't see much bipolar, but we excluded bipolar parents. So that's a little bit of our data is really not accurate in that. We can't say much about that. If you treat the depressed parent to remission, it can ease the effects on the child. This is not to say it'll go on forever. For us, it went on for a year after the mother's remission, but that's as far as we could follow it. And it might be that this is a chronic illness, and as the mother has recurrences and is treated, that you might have the same effect on the child. And maybe this should be coupled with other types of intervention. I mean, it would be nice to do a study in which you added parenting for some of the mothers. And it might be good to also provide treatment for some of the children who have more severe depression. We did not treat these children, and very few of them were receiving treatment, but we did see their improvement. The perinatal period is a time to begin screening. As you said 30 years ago, that's the time, because you get a twofer. And in fact, we would say you get a more than twofer if it's not a prime IP, because if there's other children in the family, you can have a big impact. The choice of treatment is unclear. We would, of course, say, as the World Health Organization says, that if a woman is depressed and pregnant, you should start with psychotherapy. We cannot be definitive about the effects of SSRIs. We've only done one study, and hopefully we'll get funded to try this out in other databases, but so far we haven't. The long-term safety of medications on the developing fetus, all we can say is unclear. And I know that clinicians who are treating depressed pregnant women are in a dilemma, because you want to get them better, and if they've had a response to medication. And I know some women say, I'm just not going to get off my medication. That is a dilemma. Not everyone with depression needs psychotherapy. I mean, we have people come, they don't want to talk about their problems. You know, time sometimes works very well. And that's why if you have a very low-key intervention that tries to figure out with the patient, maybe in one session, what brought on the symptoms, what in their life, transition or grief or a dispute, sometimes they figure it out on their own what to do with them. Medication alone, exercise, yoga. Working with the World Health Organization, they use yoga a lot and mindfulness. You have Marcia Linehan here, who is quite an expert on Zen and mindfulness. We've never done it, but I certainly wouldn't dismiss it as a possible good treatment for some people. There are several evidence-based psychotherapies. I know IPT, but there are a lot of others. Not a lot, but there is at least 11 that have good evidence. And they can be administered by trained health workers in a triage model, which is if the patient doesn't get better at the end of a reasonable length of time, the patient should be triaged to a higher level practitioner. Some patients get better and don't want to go beyond 3 sessions. When we worked in primary care, the average stay was about 3 sessions, 3 to 5 sessions. I mean, those of us who work in New York think everybody wants to be in psychotherapy all the time. But when you have a cross-cultural view, like maybe on the West Coast, that's not the case. The evidence for psychotherapy is emerging. I think there's been a lot of evidence. It's not widely available, and it's decreasing in the United States. The resource-poor countries, through WHO and the World Bank, are increasing the availability of evidence-based psychotherapy in primary care by health workers who do not have a lot of education, but are trained. And those are the people they have to do this work. They are doing implementation studies, not really clinical trials. But we did do a clinical trial in Uganda and showed that you could do it and that the treatments do work. I didn't bring my IPT slides with all of those. So this is the paradox. What's being used in resource-poor countries is too expensive in the United States. That's really hard to understand. And then these are all the people. This is who gives me money. We will always be happy to have more money and donors. I don't want to compete with you, but we will if we can. And this is just part of the crew that have done the studies on the 3 generations. I don't have my IPT people here, but it takes a lot to do this work, as you well know. Thank you. So we have 15 minutes, good.
Thank you. Lots of people have questions for you, so if it's okay, I'll just let them fire away at you.
Okay.
All right.
Can you restate the question?
I'll restate the question. Yes.
Are you looking at the hypothesis that the level of severity of depression may be part of that issue involved with SSRIs and pregnancy, and that people stay on longer because they're iller?
Yes, of course, that's a major criticism of an observational study. And that's why we looked at discontinuation. We also looked at dose. We looked at everything we could. And that's why I can't stay here. You can't have SSRIs because it's going to cause that. What we need to do is try to replicate this in other birth cohorts. And I just heard about one that might be available here, and we're going to ask. There's nothing more we can do, but we shouldn't not do it or not publish it because it's observational. Yep.
I wonder if this idea of time is what's behind the decline of psychotherapy in this country. And maybe it's the future of how we might see trends internationally too, in that, you know, as we get more into multitasking, we don't have time for 12 sessions of psychotherapy. And that perhaps, I mean, I'm wondering what you think about this, perhaps the future of research, both domestically and internationally, with psychotherapy is looking at the effectiveness of shorter term treatments.
Absolutely. Is the effect, can we hope for psychotherapy continuing if we do it shorter? Absolutely. And for Muslim countries, that's primary care, we're recommending that if the patient does well 2 consecutive sessions and they want to terminate, you terminate, and that you probably don't go more than 5 sessions, because if they need more than 5, because there's a whole family structure to help facilitate, then they may need a different kinds of treatment. I think you have to. And also, most people don't want to stay that long. Yes?
What
are your thoughts about computer-based therapy delivery rather than face-to-face or person involved?
Okay, what about computer-based? I'm in great admiration for it, but haven't been able to do it. Ellen Frank has with bipolar, but she's focusing on social rhythms. And I've read what she's done. I haven't seen it. Nancy, I'm sure, knows about it. We are working with a company in Holland to try to use some kind of an app that would do IPT. We had one session in my apartment where we took this beautiful manual that we had written with scripts, and we were very proud of that. And when we try to do that as an interaction, it really didn't work. So I think it's very hard. And there are people who know how to do it. I don't, but I hope we do.
For that kind of development, I think you have to all be texting each other from in your own apartment, in the same room.
Yeah.
I was wondering, I was in the women's clinic here, we do a lot of screening for depression, do you have any suggestion of what screening tools? Currently we use the PHQ-9. We also are trying to use the Edinburgh for depression screening more, although that's really slow in the process. Do you have any thoughts on that?
You asked the right person. What screening tools should you use for pregnant women? The reason you asked the right question is, I guess all of the major places in obstetrics are going to do screening. They're following the Preventive Task Force recommendation. So we have our group at Columbia, and Catherine Monk and I were assigned to review the screening scales. So we just did. There's the Edinburgh, the PHQ-9, and there's one more that's called the perinatal scale. And as far as we can see, there's no difference. And we even asked Kathy Wisner, who is an expert, there's no difference really in the PHQ versus the Edinburgh on sensitivity and specificity. I favor the PHQ-9 because women aren't just depressed, aren't just pregnant. They get to be non-pregnant, and they're also a men. And if you use the PHQ-9, you will be able to have the scores that the women have on the same scale with the same assessments that's used for men and non-pregnant women. So I am much in favor of that, not to have something special for the women, which then becomes separate and different. People in obstetrics and gynecology probably disagree with that, but you can't go wrong with using either one of those.
Follow up on that. We see a lot of people who English is not their first language, and just culturally, some of those questions are really hard to interpret. Do you have any thoughts about that piece too?
Which ones, on the Edinburgh or the PHQ? Well, I don't really know much about the Edinburgh. We use the PHQ-9 in our primary care clinic at Columbia for 1,000 women. Only 72% spoke Spanish. And most of them are Dominican or Puerto Rican, and many of them, the Dominicans, don't have a high level of education. And we then tested it against an independent assessment in 400 women using the SCID. And it works pretty well. And the thing we found that we had to do is, if somebody says, I can't read it, I don't have my eyeglasses, you assume they can't read it. And you don't wait for them to get their eyeglasses, but you read it to them. Because in our population, the rates of illiteracy were high. We also had it translated in Spanish, so it wasn't that. But there were some people, at least in our community, who can't read. Nancy's shaking her head, so you probably have had, you're the expert on.
PHQ-9 and Edinburgh in our recent clinical trial, and found that we like the PHQ-9 better because it can also ask about impairment. So you can approximate a major depressive episode diagnosis. And so we found it both because it measures severity and it can measure categorically. So we like that. And the women were from many different backgrounds, but Mary did the interview a lot. So they tended not to have too many problems.
Just some feedback on that. sometimes with the PHQ-9, because they're rating sleep, eating, and tiredness as a 3, it shows as depression when that's a normal thing in pregnancy. So I guess that would be my only concern about how accurate that is.
Easy to handle that. Change the cutoff score. But you know, you can't go wrong using either one. I just prefer.
Well, you can either change the cutoff score or you can require one of the core symptoms of depression.
Yes.
Yes.
If all you have is the physical symptoms, then maybe you're off, right?
Yes.
You can just say, if they don't have any anhedonia, if they don't have any kind of a mood effect, you might not have depression, right?
Yeah, that's of course another way to do it. That's actually a good. We have a conference call next week. I'm going to say that. Yeah, Dave.
There aren't that many things in psychiatry that have been replicated, but one of the things has been assortative mating, the tendency of people with an illness to marry people with an illness. We showed that with depression.
I know.
Other people have replicated it. What are the findings in your studies of multi-generations about spouses of these patients, and what impact does having 2 depressed parents have on offspring?
Well, obviously, what's the effects of assortative mating? Obviously, there's 2 parents with depression or another disorder. It has an impact on the rates. In this particular sample, there wasn't enough to make anything definitive, but we have done it in other studies, in our large family genetic studies, and there you see what you found, that 2 is worse than 1.
So you have to treat both parents.
Yeah, I haven't done that study, but it would sound, it's usually better to treat the mother if the mother's depressed, because in most families, the mother has the caretaking. If the father had the caretaking, sure, treat the father. Yes?
In terms of children with the high-risk families who are depressed, what have you seen or studied about their responsiveness? Now, we have enough evidence about how SSRI is controversial, and we try to work with CBT and SSRI. But what have you seen, since now they have a biological predisposition, in terms of their responsiveness by the time they attain puberty and they're depressed? Is there more evidence for SSRI versus CBT or both? Or do you see that?
Are you talking, what's the evidence for CBT versus SSRI?
In terms of these children who are coming from these high-risk families.
You know, they get poor treatment, and there isn't much we can say about the effects of treatment. And in fact, in a longitudinal study, remember this is 30 years, you see a direct effect between the amount of treatment and the child's outcome, with those children who have the most treatment have the worst outcome. And that's because if they're sicker, they go for more treatment. So you need a clinical trial. There are clinical trials comparing CBT to medication and IPT to medication. And I think Pam Cooper's done a review of that, a meta-analysis recently, and it sounded like they come out about the same.
What
But
I was going for was biological predisposition. Does it mean that if the mom or the grandmother was an SSRI, then there is more evidence for the child to respond to SSRI?
yeah, that's a very good question.
Right,
That hasn't been done, or at least we haven't done it. Any other questions? Yeah. Go ahead.
How do you think that your longitudinal study is impacted by kind of the sampling bias of the social stigma around talking about depression, socioeconomic aspects of the patients that actually got to participate in that study?
How do I think that stigma?
Yeah, well,
And so,
you know, who you got into the study, you know, that might play a large role into the continuing generational effects of depression.
well, I see it more in terms of the problems we have. We're doing a study in African American churches in Harlem, and we use distress and stress. We don't use depression because there's a lot of stigma. And also we use the clergy to do the education, not ourselves, and we don't do groups because people are very cautious about talking about mental illness. In this particular sample, over 30 years, our response rate is very high, but over 30 years, they feel comfortable talking to us. And in fact, when there was a suicide last month, we were called very early to be told. So I think in this particular sample, which were mostly lower middle class Italian, that is not an issue. But it certainly is an issue. And you have to be very sensitive when you do cross-cultural things. For example, in Uganda, you couldn't do individual therapy. You only could do in groups because nobody would trust you sitting in a room alone with a woman. And what would she be saying? Or a man even. Whereas in Harlem, you can't do groups. And we call it stress and distress. Okay. Thank you.